Hello, I am Yoon from Asan Medical Center. It's a great honor to share our work with Korean Journal of Radiology. Our research is on the validation of CT-based risk stratification system for lymph node metastasis in patients with thyroid cancer. Although DTC has an excellent prognosis, cervical lymph node metastasis is present in 20 to 50% of patients at the time of diagnosis and associated with poor survival outcomes and increased risk of recurrence. Currently, it is accepted that most recurrent disease following initial curative therapy for DTC represent persistent disease due to incomplete preoperative staging and subsequent incomplete surgery. Therefore, accurate preoperative assessment of lymph node metastasis is warranted. Although ultrasonography is the modality of choice for preoperative evaluation of lymph node metastasis, it is an operator-dependent technique and has limited ability to visualize mediastinal, infraclavicular, retropharyngeal, and parapharyngeal areas. Meanwhile, CT offers some advantages over US, including the ability to provide unlimited coverage of the neck and detailed anatomic information. The K-thyroid suggests 4 suspicious features: cystic change, calcification, strong enhancement, and heterogeneous enhancement for diagnosing metastatic lymph nodes on CT, and provides a CT-based risk stratification for lymph nodes according to their malignancy risks. However, there are a few studies investigating whether each suspicious CT feature suggesting a metastatic lymph node is appropriate. Thus, in this study, we aim to evaluate the CT features for diagnosing metastatic lymph nodes in patients with DTC and validate the CT-based risk stratification system suggested by the K-thyroid guidelines. The flowchart illustrates the selection process of the patients. A total of 463 lymph nodes from 399 patients were included in the study. The following is the CT protocol for our study, which includes the arterial phase in dual energy mode, delayed phase, and the virtual non-contrast images. CT and US images were matched on a node-by-node basis, and the FNA-confirmed lymph node was labeled on the CT. 2 neuroradiologists independently analyzed the CT images, and any discrepancies were resolved through consensus. The following CT features of the lymph nodes were evaluated: presence or absence of a halo structure, cystic changes, calcification, strong cortical enhancement, and heterogeneous enhancement. For example, this axial CT scan shows a lymph node with preserved hilar fat and vessels, but no cystic changes, calcification, strong or heterogeneous enhancement. Thus, it would be classified as probably benign by K-thyroids. In this case, the absence of a hilar structure and no other suspicious feature in the lymph node lead to its classification as indeterminate. The lymph node displays cystic change with eccentric, strong enhancing solid portion, giving the lymph node a heterogeneous enhancement pattern. It would be classified as suspicious category. In this case, the lymph node shows a discrete calcification on the pre-contrast CT image on the top, while displaying strong and heterogeneous enhancement on the post-contrast image. The evaluated CT features were used to classify the lymph nodes into 3 categories according to K-thyroids: probably benign, indeterminate, and suspicious. Lymph nodes were finally diagnosed as metastatic or benign based on the cytology and washout thyroglobulin level as follows. We compared the clinical radiologic features between metastatic and benign lymph nodes and determined the independent CT feature associated with metastatic lymph nodes using logistic regression analysis. Based on the outcomes of the multivariable logistic regression analysis, we proposed a modified lymph node classification system. Then, we compared the diagnostic performance of K-thyroids and modified lymph node classification. A total of 463 lymph nodes were included in this study, of which 97 were benign and 366 were metastatic. The metastatic lymph nodes were associated with male and a larger primary tumor compared with benign lymph nodes. The short diameters of metastatic lymph nodes were significantly larger than those of benign lymph nodes. In the multivariable analysis, the absence of a hilum, strong enhancement, and cystic change were independently associated with metastatic lymph nodes. However, heterogeneous enhancement was not independently associated with metastatic lymph nodes on multivariable analysis. Because all 21 lymph nodes that showed calcification were diagnosed as metastasis, the value of calcification could not be interpreted. This table demonstrates the diagnostic performance of CT features. The absence of a hilum showed the high sensitivity for diagnosing metastatic lymph node, but the lowest specificity. Lymph nodes with cystic change and calcification showed very high specificities, but sensitivities were low. Lymph nodes with strong enhancement showed high sensitivity, moderate specificity, and the highest diagnostic accuracy. Heterogeneous enhancement showed moderate sensitivity and specificity. This table shows the diagnostic performance of each suspicious feature alone without other suspicious feature. When we investigated the relationship between the CT features, the heterogeneous enhancement was significantly associated with both strong enhancement and cystic change. However, no significant association was found between strong enhancement and cystic change. Only 10 lymph nodes showed heterogeneous enhancement alone without any other suspicious features. Based on the results of our study, we proposed a modified lymph node classification that excludes heterogeneous enhancement among the suspicious features. The overall malignancy risks across the probably benign, indeterminate, and suspicious categories of K-thyroids and the modified lymph node classification are detailed as follows. In our modified lymph node classification, the malignancy risks for indeterminate and suspicious categories were higher compared to K-thyroids, while the risk was lower for probably benign. By excluding heterogeneous enhancement as a suspicious feature, 10 lymph nodes categorized as suspicious lymph node on K-thyroids were reclassified into the indeterminate or benign category. The modified lymph node classification led to a decrease of 7 false positive cases and an increase of 3 false negative cases. The modified lymph node classification demonstrated higher specificity and PPV compared to K-thyroids. The heterogeneous enhancement was not an independent feature for diagnosing metastatic lymph node. There was an association between heterogeneous enhancement and cystic change or strong enhancement. Only a small percentage showed heterogeneous enhancement alone without any other suspicious features. Because of this association, it is thought that heterogeneous enhancement was not an independent feature suggesting metastasis. Therefore, we propose a modified lymph node classification that excludes heterogeneous enhancement from the 4 suspicious features of K-thyroids. Excluding heterogeneous enhancement as a suspicious feature resulted in greater divergence in malignancy rates among each category and higher specificity and PPV for diagnosing metastatic lymph nodes compared to that of K-thyroids. By excluding heterogeneous enhancement as a suspicious feature, we could avoid unnecessary biopsies and simplify the risk stratification system, potentially reducing inter-observer variability. However, it is important to note that 3 more false negatives were identified. It is crucial to acknowledge the potential consequences of missed metastasis, and a comprehensive evaluation of the risks and benefits associated with this approach is essential. In conclusion, our study demonstrated that heterogeneous enhancement was not an independent feature indicating metastatic lymph nodes. Excluding heterogeneous enhancement as a suspicious feature resulted in higher specificity and PPV for diagnosing metastatic lymph nodes compared to that of K-thyroids. Our research results may provide a basis for revising lymph node classification in future guidelines. Thank you for your time and attention.